The skin. The skin is composed of 3 layers: the epidermis, upon or on top of the dermis, the dermis, and the hypodermis, under or beneath the dermis. Most of the epidermis is made up of keratinocytes. These are cells that produce keratins, cytoskeletal proteins that form a protective barrier. It also includes some melanocytes, which produce the brown pigment melanin. The middle dermis is composed of connective tissue and contains blood vessels, hair follicles and their associated sebaceous glands, and sweat glands. The hypodermis, or subcutis, consists mostly of fat or adipose tissue and varies in its thickness. It is still not known what causes many skin diseases, and as a result, proper treatment is often difficult to determine. To understand skin diseases better, however, it is important to be aware of what is known about the skin. These skin facts include protection. When the skin is dry and undamaged, it forms an effective barrier against infection. Skin can be damaged by physical or mechanical injury, very hot or cold temperatures, caustic or toxic chemicals, or exposure to different types of radiation. The effects of acute injury differ from chronic or repeated injury. For example, short-term exposure to intense radiation can lead to sunburn, which presents as a first or even second-degree thermal injury. Repeated exposure to the sun, however, allows the skin to tan gradually and can lead to premature aging or the development of tumors. The surface of healthy skin is teeming with hundreds of different kinds of bacteria. These bacteria remain harmless until the protective barrier of the skin is breached, when they may infect a wound. Researchers have recently discovered that different parts of the body tend to harbor distinct communities of bacteria. These bacteria may be clues to the causes of skin diseases, because each disease tends to occur in a specific site on the body. Other important facts about the skin include it reacts to foreign substances. The skin, as you have learned, is the immune system's first line of defense. A disease may not originate in the skin, but the skin is often affected by disease, especially one that is systemic and/or metabolic, such as diabetes, or involves the immune system. Diseases may present with hypopigmentation, as in albinism, or hyperpigmentation, as in sun tanning. It is the most common site of tumors. It has a limited range of responses to injury. For example, blisters can be the response to burns, allergy, a systemic disease, or some other primary skin disease of unknown etiology. The major diseases that involve the skin can be classified into 5 categories. Traumatic lesions caused by mechanical, chemical, or thermal injury, infectious diseases, immune system disorders, metabolic diseases, and those diseases that arise secondary to a disease of an internal organ, and neoplasms or tumors. Because the skin has such a limited response to injury, it is important to be able to distinguish the types of skin lesions that can occur. The most important are illustrated in this figure. Macule, a change in skin color, more red or brown. The best example is a freckle. Papule, small, rounded shape, slightly elevated and hardened. It's a feature of eczema. Vesicle, small, fluid-filled elevation, typical of cold sores, shingles. Larger vesicles are called bulla, or more commonly blisters. Pustule, vesicle filled with pus, typical of impetigo, acne. Plaque, a scaly or squamous patch of skin, can become quite large, typical of psoriasis. Ulcer, a lesion of the epidermis that exposes the dermis. An example is a chancre caused by syphilis. Nodule, similar to a papule but larger and often pigmented. An example is a mole. Congenital disorders of the skin may present at birth or some time later in development. They include birthmarks, nevi or moles, a rare genetic disorder called ichthyosis, where the child is born covered in scales, albinism, and epidermolysis bullosa, characterized by the spontaneous formation of blisters. External thermal injury to the skin can occur through brief exposure to extreme hot or cold, or long-term exposure to moderately hot or cold temperatures. Burns are classified according to the depth of skin injury. First-degree burns affect only the epidermis and result in redness, erythema, and swelling, edema. They heal spontaneously and damage is reversible. In second-degree burns, damage does not extend into the dermis, but the epidermis becomes blistered. Such burns will heal gradually without scarring. Third-degree burns result in massive necrosis that extends through the epidermis into the dermis, and sometimes into the underlying subcutaneous tissue, the hypodermis. Smaller areas will heal very slowly with scarring, while larger areas will not heal spontaneously at all and require specialized treatment, such as skin grafting. With extensive burns, it is necessary to estimate the total surface area affected in order to determine appropriate treatment methods and chances for survival. Physicians use the rule of nines, which subdivides the body up into 9% areas. 9% for the front and back of the head, 36%, 4 times 9, for the front and back of the trunk, 18%, 2 times 9, for the front and back of the arms, and 36% for the front and back of the legs, which leaves 1% for the perineum, bringing the sum to 100%. Cold injuries are usually less severe than burns. Immersion foot or trench foot is a condition caused by prolonged exposure to non-freezing cold, damp environments. Affected feet become numb, blood flow slows and stagnates, and skin necrosis may develop, resulting in blisters and ulcers. Frostbite is caused by exposure of any part of the body to sub-freezing temperatures and progresses similarly to immersion foot, except more quickly and usually with more severe necrosis. The type of injury caused by radiation from the sun depends upon the duration of exposure. Acute exposure causes first or second degree burns with redness and the formation of blisters. Chronic exposure leads to hyperpigmentation, premature aging, wrinkling and loss of elasticity, and possibly cancer. Bacterial infection of the skin may be primary, secondary, a complication of a pre-existing skin disease or injury, or systemic, one of the manifestations of a more general infection. Purulent or pus-forming bacterial skin infections can range in severity from impetigo, which is limited to the epidermis, to folliculitis, which is limited to the lumen of the hair follicle, to a furuncle, or small boil, which extends into the dermis surrounded by a single follicle, to a carbuncle, or large boil, which spreads into adjacent follicles. Here are 2 examples of 2 common primary bacterial skin infections, impetigo and folliculitis. Fungal infections of the skin are quite common, but fungal pathogens, or dermatophytes, prefer to live in dead tissues, such as the keratin layer on the skin's surface, nails, hair. With the exception of some deep invasive fungal infections endemic to the southern U.S. and tropics, most dermatophyte infections rarely extend into living tissue. Yet they cause the sufferer to scratch and therefore can make the skin more vulnerable to secondary bacterial infections. Fungi also tend to colonize intertriginous parts. These are areas where two skin surfaces touch or rub together, such as in between the toes, the axillae, or armpits, and the groin. The more common fungal infections are referred to as tinea, or ringworm. Tinea corporis is the term used to describe a superficial skin infection anywhere on the body. Note the ring shape. Tinea unguium refers to a fungal infection of the nails. Viral skin infections can be chronic, such as the common wart caused by the human papillomavirus, or they can be acute. Acute viral infections include measles, an example of a maculopapular lesion, a combination of a reddened macule and a papule; chickenpox, an example of vesicles; herpes labialis, cold sores or fever blisters; or herpes zoster, shingles, both of which are good examples of vesicles. The bites of arthropods, which include insects, ticks, and mites, can cause itchy maculopapular skin lesions. Blood-sucking insects include fleas, mosquitoes, bed bugs, and lice. Blood-sucking ticks cause maculopapular lesions. The tiny mite that causes scabies creates a distinctive lesion as it burrows into the epidermis. Bites, of course, can not only cause skin lesions, but may transmit serious systemic diseases such as typhus, caused by fleas, Lyme disease, ticks, malaria, and West Nile virus, caused by mosquitoes. Here is an example of a single blood-sucking bedbug. Infestations of this tiny insect cause maculopapular lesions. Head lice, another tiny insect, infest the hair and can cause maculopapular lesions in and around the scalp. Scabies is caused by a tiny mite that leaves a distinctive trail as it burrows. Subsequent scratching and immune reaction tends to lead to maculopapular eruptions. Most of us are probably familiar with acne, its risk factors and probable causes. The pathogenesis of acne, however, remains somewhat uncertain. It usually begins at puberty when sex hormones cause the sebaceous glands to produce more sebum. These same hormones stimulate hyperkeratosis, which leads to the development of a keratin plug that prevents the discharge of sebum. Blocked sebum festers, and the follicle expands and eventually ruptures, discharging infected sebum into the surrounding dermis. Pustules and papules form, which, if not allowed to heal properly, can lead to scarring. Eczema is a term used to label many forms of chronic dermatitis. It is characterized by superficial, non-specific lesions such as localized edema, papules, and vesicles. Eczema always presents with pruritus or itching. It is often classified into two types: exogenous, outside environmental cause such as a chemical irritant or allergen; or endogenous, unknown cause or a manifestation of a systemic autoimmune disorder. About 10% of children suffer endogenous eczema, referred to as atopic dermatitis, which has a presumed immunologic basis and runs in families. Seborrheic dermatitis is a common multifactorial disease of unknown origin. It presents with reddening, scaling, and itching skin. On the scalp, in particular, is referred to as dandruff. It affects not only the scalp, but nasolabial folds, eyebrows, upper chest, and sometimes the axillae and groin. Psoriasis is another common skin disease of unknown origin. Because it is more common in some families, it seems to have a genetic component. Psoriasis presents with slightly elevated papules, usually found covering the easily traumatized skin on the kneecaps or extensor surfaces of the elbow, or on the scalp or nails. The papules erupt in crops to form scaly patches, large plaques, that typically do not itch. Outbreaks seem to be related to emotional stress or trauma. Here is an image of a psoriatic plaque on the knee. The skin is the most common site of neoplasms on the body. Tumors are divided into 4 categories: epithelial tumors, pigmentary cell tumors, connective tissue tumors, and tumors originating from blood-borne immigrant cells. Tumors can be benign or malignant and originate from different types of cells. Keratinocytes in the epidermis can develop into a benign tumor called seborrheic keratosis or a malignant tumor called basal cell carcinoma. Melanocytes in the epidermis can become a benign nevus or mole or develop into malignant melanoma. Connective tissue tumors are much less common. Fibroblasts can develop into a benign tumor called a dermatofibroma. A malignant tumor called Kaposi's sarcoma can form from blood vessels and surrounding connective tissue. Seborrheic keratosis, or senile wart, is the most common benign epithelial skin tumor. Basal cell carcinoma is the most common malignant tumor. It has a good prognosis, as it is non-invasive and does not metastasize. The epithelial tumor with the worst prognosis is a squamous cell carcinoma, which can become locally invasive and does occasionally metastasize. It is often preceded by a pre-invasive, superficial stage termed actinic keratosis, which can progress to carcinoma in situ, which is still pre-invasive, but extends throughout the epidermis. Basal cell carcinoma appears as a nodule with a central crater-like depression, or ulcer. Both basal and squamous cell carcinoma occur on sun-exposed skin and originate from keratinocytes, but basal cell comes from the cells at the base of the epidermis, while squamous cell comes from cells higher up in the epidermis. They can look similar, but squamous cell often appears more severe. Unlike basal cell, squamous cell carcinoma can also present as a flat or slightly elevated scaly plaque. The word squamous means scaly. Some of the signs of skin cancer originating from keratinocytes include the appearance of a thick, scaly, or crusty patch of skin, called a plaque. This is a lesion typical of actinic keratosis, the precursor to squamous cell carcinoma. A persistent, non-healing ulcer, an ulcer or nodule of irregular shape or indistinct margins. Friable, which means easily broken apart, multicolored, bleeding tissue in an ulcer. Indurated, which means hardened, margins on an ulcer or in the surrounding tissues. Melanocytes in the epidermis can form pigmented skin lesions, which vary from the freckle, the lentigo, to the nevus or mole, which is a benign tumor, but may progress to malignant melanoma, the most malignant of all skin tumors. About half of malignant melanomas emerge from intact skin without lesions. The other half develop from a freckle, lentigo, or mole. This slide contrasts the benign pigmented nevus or mole with a malignant nodular melanoma. Note the differences in size and shape and the characteristic irregular border of the melanoma. Several clinical pathological types of melanoma are recognized. Lentigo, maligna, or malignant freckle, which is usually found in elderly people. Superficial spreading melanoma, which is the most common type. It forms itchy, irregularly pigmented macules that enlarge and can become increasingly invasive, eventually progressing to nodular melanoma, which is a rapidly growing nodule that invades the dermis and deep into the hypodermis or subcutis. There's also acral lentiginous melanoma, which develops on the palms, the soles of feet, and underneath the nails. It is the most common form in blacks and Asians. Less common connective tissue tumors include a benign tumor that originates from fibroblasts called dermatofibroma, and a tumor of low malignancy called Kaposi's sarcoma, which used to be very rare. Since the relatively recent epidemic of AIDS, however, its incidence has increased dramatically.